Yeah, so we'll go to the next presentation, Do and Don'ts in Premium IOLs by Dr. Subodh Purohit. He is from Yavatmal, Maharashtra.
Good morning, everybody. I'm going to speak on do's and don'ts in premium IOLs. After the birth of your child, if any surgery is more satisfying, that is the cataract surgery, I guess, and everybody will agree with this, provided you give a good vision to the patient. Now, basic aim of a premium IOL is to convert the cataract surgery into a refractive surgery. Now, what are the pearls for cataract surgery to be a refractive surgery? Pre-op pearls, we can divide into pre-op pearls, intra-op pearls, and post-op pearls. Now, pre-op pearls for a premium IOLs, choosing a right patient is half battle won. Now, points to be considered for pre-op counseling, that is for the premium IOLs: acknowledge the patient need for near and the intermediate vision. Understand, is there any high level of concern, fear of a night vision related issues? Make sure that the patient understands that the neural adaptation is a process. And also make sure the patient has realistic expectations. If a patient is asking too many questions, if a patient is becoming more of an advocate, avoid such patients. There should be difference between, this is the most important thing I would like to say, seniors will agree with this. There should be a difference between selling the lens and educating the patient about the options available about the lens. Now, going for a preoperative assessment, ocular surface and tear film evaluation, rule out any ocular comorbidities, avoid any anisotropic or high myope or amblyopic patients. Preoperative refractive surgery, if at all patient has undergone, try to educate the patient, tell him that there is increased propensity of glare, halos, or IOL power calculation, so avoid such patients. Now, though you are an anti-segment surgeon and the patient has got no retinal problems, but just make sure you go for a OCT pre-op assessment, and if at all, if you are in doubt, don't shy away to take the opinion of your retinal colleague. Now, too much of information will confuse the patient. Sorry, there is no interest in politics, though there are dates to be available, to be declared today, I guess. Don't confuse the patients like EDOP, multifocal, hydrophobic. Just imagine if you've got a MD medicine colleague and if you say all these things, even he may get confused. So for a layman, it is very difficult to understand EDOF, premium, toric, bifocal, and everything. So avoid such confusion. Then after convincing the patient, go for the measurement of premium IOLs, because outcome depends on multiple factors. Precise preoperative measurements play an important role. And also, role of an advanced diagnostic technologies is more important for the perfection. Accurate biometry requisite, that is, you have to go for a keratometry, because we need magnitude of astigmatism and also the axis of astigmatism. Then axial length, AC depth, lens thickness, effective lens position. Because nowadays the new formulas are based on the effective lens position and all these parameters. Optical biometry is must nowadays, like IOL Master 500, 700, lens star, because these give the keratometry markers of 1.65 mm and all the newer things to it. Because accuracy of IOL power is more important, because just guess you're going to stitch a suit for wearing into your wedding programs, and if you're buying like 10,000 per meter suit, but if it is not fitting you, it will make no sense. Now, applanation scan has got error of 0.24 mm, immersion scan like 0.12, and the most optical biometry is the most accurate, I'll guess. Now, appropriate formulas based on the axial length is very important, but for large, we can go for Barrett Universal 2 for most of the range of axial length. Then another thing I usually follow in my practice is triangle of agreement. That is, I usually take the 2 or 3 readings, which usually for, you can taper it to your common lenses you are using, like for Alcon, for IOC and others. If Haig's formula is perfect for you, or SRKT or Barrett Universal 2 is perfect. So take 3 and take best out of these 3. Then astigmatism and premium eyes, like preoperative corneal astigmatism, it is less than 1 diopter, go for multifocal or EDOF lenses. If it is more than 1 to 2.5, go for multifocal toric or the toric monofocal. If it is more than 2.5, monofocal toric I usually prefer, but we can go for toric multifocals also. Now, astigmatism update, initially we used to only consider anterior corneal astigmatism, but nowadays we have to add to posterior corneal astigmatism, SIA, and which is the total astigmatism. Now, understanding the posterior corneal astigmatism, because nowadays from last 5 to 7 years, we are talking too much about posterior corneal astigmatism. This means if the corneal astigmatism is calculated from measurements taken from anterior cornea only, we may land up in overcorrection in with the rule astigmatism or undercorrection in 0.30 in the ATR, that is against the rule astigmatism. Now, optical system alignment is also important because the IOL tends to center on the limbal center and not on the visual axis. If you got a large angle cup alpha, that is 0.5 mm, avoid multifocal or the toric lenses. EDOF lenses is debatable. We can go for EDOF lenses. Now, if you can afford eye trace, if it is available, if there is too much of aberrations, avoid such patients. Needless to say, intraoperative pulse like incision should be perfect. Rexis should be 5.5, 360 degree, overlapping the IOL optic. Nucleotomy, if it is hard cataract or even if it is grade 3 and you're going for a premium lenses, don't shy away or don't do any conjugacy in using viscoat or high molecular viscoat. IOL stability is more important. Go at polishing and centration, especially in the toric lenses. Now, you always don't need flax. You can go with the manual CCC and this already. This is another important point I would like to say. These are the IOL centration. This is a P1 image, Purkinje image 1, which is with the base down and the apex at the top. The second image, that is P2, which is on the posterior surface of the cornea, which is a little bit blur. And P3, that is the Purkinje image 3, which is on the anterior surface of the lens. And P4 is the inverted triangular mark on the posterior surface of the lens. And what you have to do in alignment is you have to match Purkinje image 1 and Purkinje image 4 for the accurate alignment of the lens. Even after doing so many things, you may land up with the unhappy patients. You may face unhappy patients. I say there are 6 C's, like cornea and ocular surface disease, cylinder, residual refractive error, capsular opacities, and the last but not the least is crazy patients. Now, negative dysphotopsia, like temporal peripheral pencil beams, when they hit the lens edge, and it may cause the shadow on the retina and may give rise to negative dysphotopsia. So I'll just get a couple of minutes, please. Positive dysphotopsia, glare, halos. We all know that these are the problems with the rings associated multifocal lenses. Now, neural adaptation is just like your spouse adaptation. I would have said only about the wife adaptation, but since females are sitting over here, I'll say it is like your spouse adaptation. It takes around 3 months to 1 year to get adjusted. So, खुद ही तो कहते थे मुझे खुद को बदल लो, खुद ही तो कहते थे मुझे खुद को बदल लो, अब बदला हूँ तो कह रही है अब वो ना रहे तुम. It is just a neural adaptation, but you have to get adjusted to it. Now, rotational stability, like rotation of 3.3% of lens cylinder will be lost for every 1 degree of IOL rotation. And if at all you find any disparity in the toric lens, you can go for astigmatismfix.com and realign it. To summarize, start with the hypermetro female patient, know patient's occupation very well, precise IOL power calculation. Multifocal and toric lenses are very sensitive to residual refractive error. The newer generation formula should be used, and important thing is promise less and deliver more. And after doing all this gymnastic or circus, even if you land up in some surprises of a cylindrical residual axis or, for example, spherical even, I'll say not all the post-operative patient with glasses would be unhappy and complaining, because we know one person or we know one patient who is happy with the glasses, and you all know this. Thank you. Pseudophakic patient, we all know. Thank you.
Well, thank you, Subodh. It was wonderfully covered. And I think if I have to sum up the premium IOL thing, before you actually commit to a patient for premium IOL, certain diagnostics should be a part of your armamentarium, like which you've emphasized about the OCT, the dry eye management, the good optical biometry, the specular and other stuff. We still have about 3 minutes. If anybody has any query, they can put up their question.
Most important point I like is that you should counsel the patient beforehand, and don't deliver more and promise less. These two things are very important for premium IOLs, I suppose. Thank you very much.